Videolaryngoscopes are rigid, indirect laryngoscopes which drop your line of sight to near the end of the primary curve of the upper airway. In doing so, they are essentially allowing you to look round the corner. For QA, we have all the following devices. The AirTrack is an example of a channel videolaryngoscope, with the other three being unchanneled. All of these videolaryngoscopes have strengths and weaknesses, but in the hands of an operator who is trained to use them, they all have the potential for very high intubation success rates. It is not possible to get away from the fact that videolaryngoscopy guided intubation is a very technical procedure. In this talk, I'm going to go through the technical points that can lead to successful unchanneled videolaryngoscopy. I'm not going to discuss the AirTrack, which has its own. GlideScope, CMAC, and are all available with both Macintosh. Macintosh blades can be used to perform direct laryngoscopy with the naked eye. They also have a screen.
Really bad feedback.
The hyperangulated blades require you to view the video screen in order to see the larynx. Of note, the McGrath Mac blade is actually more angled than standard Macintosh blades and has an almost intermediate angulation. In comparison to Macintosh direct laryngoscopy, Macintosh videolaryngoscopy affords an improved view. This graphic depicts an example in which it is possible to see just the posterior half of the vocal cords on direct laryngoscopy with the line of sight of the anaesthetist seen in blue. As the camera is near the tip of the curved blade, it affords an improved view which can be seen in yellow, and in this case the entire vocal cords can be seen. There is plenty of evidence to support that this is a clinically significant improvement of view, and I'll come to that in a moment. Of note, it's a worthwhile option during training for a junior anaesthetist to practice Macintosh direct laryngoscopy whilst the supervisor looks at the video screen. I have heard trainers say that it is helpful because they can see what the trainee can see. It is important to realize that this is not correct, and the trainee's view of the larynx may be significantly reduced. This relatively straight line of red arrows depict the path of the endotracheal tube when using a Macintosh blade. If it is possible to visualize the laryngeal inlet with the Macintosh blade, then delivery of the endotracheal tube to the larynx and advancement down the trachea is usually straightforward. Bougies work well with Macintosh blades. This is an example of one of many studies that show the benefit of Macintosh videolaryngoscopy over Macintosh direct laryngoscopy. In this case, 300 patients with predicted difficult airways were randomized to being intubated with a conventional direct laryngoscope or with a Macintosh videolaryngoscope. The blue bars depict the videolaryngoscope patients, and you can see that there were far more grade 1 laryngoscopies and far fewer difficult laryngoscopies. This translated into a clinically important improved first pass success rate, but it is notable that it took consistently longer to achieve intubation when using videolaryngoscopy. It is notable that there remain some patients in whom visualization of the larynx was poor and intubation failed at first attempt, and these are patients in whom hyperangulated blade videolaryngoscopy may be particularly beneficial. So, with Macintosh videolaryngoscopes, we can expect laryngeal exposure that is better than with Macintosh direct laryngoscopy, and much more often than not is good. Delivery of the endotracheal tube to the laryngeal inlet and advancement of the tube down the trachea are usually comparatively straightforward, and a bougie is a suitable intubation aid. With their increased blade angulation, hyperangulated blades can potentially offer good views of the larynx in patients where Macintosh VL does not. These are examples. The photos are not necessarily to the same scale. They each differ in the relative proximity of the camera to the tip and the field of view of their cameras. At this point, I want to stress how different the technique is to Macintosh laryngoscopy. It is not intuitive, and trying to use these hyperangulated blades like a Macintosh blade will be associated with high failure rates. Now for a number of case vignettes. This first case is one that I was called to as duty anaesthetist relatively recently and mirrors similar other cases that I've been involved in. A middle-aged man was undergoing a laparoscopic cholecystectomy on the CPOD list, and an experienced anaesthetist appropriately called for help after finding the patient was a grade 3 direct laryngoscopy and failing twice to intubate. There was a small amount of blood in the airway, but face mask ventilation remained easy. A glide scope with a low Pro 3 blade and a fast track endotracheal tube on a stellette were prepared. With supervision, the anaesthetist comfortably achieved a grade 1 view and was able to intubate the patient atraumatically. This large retrospective study of 350,000 American electronic anesthetic records between 2004 and 2014 reported a very high 92% success rate when videolaryngoscopy was used as a rescue technique after failed direct laryngoscopy. A glide scope with a hyperangulated blade was used in the vast majority of these VL cases. It is notable that there was a 1% pharyngeal injury rate when VL was used as a rescue technique, and this is something we'll come to a bit later. Time for two further short cases, both general anaesthetic caesarean sections. The first case was an urgent caesarean section in a woman with severe preeclampsia. Regional anaesthesia was contraindicated due to the short time since a dose of enoxaparin. The patient was assessed by the labour ward trainee anaesthetist, who noted that the mother had a comparatively small chin and thyromental distance. Based on this, they judged that there was an increased risk of difficult laryngoscopy and made a plan to use a glidescope low Pro 3 blade first line. On first attempt at laryngoscopy, the trainee achieved a good view of the vocal cords, but found it difficult to insert and then direct the endotracheal tube on a stellette to the laryngeal inlet. They performed face mask ventilation before having a second attempt, but this time using a bougie, which they were unable to direct between the vocal cords. The supervising consultant then used a standard Macintosh direct laryngoscope, achieved a grade 1 view, and intubated the patient successfully. The second case was a category 1 caesarean section that was managed by two trainees who were midway through their training. On airway assessment, it was judged that the patient might be difficult to intubate based on the combination of having a short draw and being Malampati 3. The primary intubation plan was to use a low Pro 4 blade with a fast track endotracheal tube mounted on a malleable stellette. On first intubation attempt, laryngoscopy blade insertion was difficult, a poor view was achieved, and the patient started to desaturate. Face mask ventilation was found to be easy with a Goodell, and the patient rapidly reoxygenated. More propofol was given, and there was a change of intubator. On the second attempt, again with the low Pro 4 blade, they got a reasonable view of the larynx, but were unable to direct the endotracheal tube on the stellette to the larynx. However, with a bit of a struggle, they were able to pass a bougie and intubate the patient. During the course of this talk, I'm going to try to address the technical points that may enable you to avoid the problems which were experienced in these last two cases. In comparison to Macintosh laryngoscopy, with hyperangulated videolaryngoscopy, delivery of the endotracheal tube to the larynx and advancement of the tube down the trachea may be quite problematic. This is because the endotracheal tube has to be delivered around the curve of the blade and then negotiate a potentially difficult angle here between the pharynx and larynx. Potential issues with hyperangulated videolaryngoscopy include can't get the blade in the mouth, no room to insert the endotracheal tube in the mouth, can't get the endotracheal tube to the cords, the endotracheal tube won't advance down the trachea, running out of time, and causing airway injury. With hyperangulated blades, an intubation aid is required to guide the endotracheal tube to and through the vocal cords. Bougies can be used successfully, but getting the right shape to get to the vocal cords may take several attempts and is unreliable. Stylets offer a reliable way of delivering the endotracheal tube to the vocal cords. We now have available stiff glide-right stylets which are pre-shaped for hyperangulated blades and which don't deform as you try to negotiate around the tongue. I would recommend that you try these. The plastic handle means that it's easy for the operator to retract the stylet themselves and they don't have to depend on an assistant. I do, however, wonder if the increased stiffness increases the injury potential compared to malleable alternatives which may deform easier. Malleable stylets are cheaper, being about £1 as compared to £6 for a glide-right stylet. However, with malleable stylets, the anaesthetist can make a mess of shaping them, and the stylet may straighten if it is difficult to negotiate around the tongue. If the hyperangulated blade is being used as a rescue, then the requirement to shape the stylet is also particularly unhelpful. Hyperangulated blade technique involves look down, look up, look down, look up. Under direct vision, insert the lubricated blade into the mouth over the midline of the tongue. Then look up to the screen and continue to advance blade tip into final position. Look down into the mouth and insert the endotracheal tube under direct vision. It is important to do this to avoid pharyngeal injury. When the tube tip disappears from view, then look up to complete the delivery to the vocal cords. You should avoid driving the tip of the blade into the vallecula as you would do with a Macintosh. This is because it increases the angle between the pharynx and the larynx, making tube passage more difficult. You can get a good feel of how good your position is by looking through the vocal cords. In this case, you can see what has been called Kovacs sign, which is when you can see the cricoid and anterior tracheal wall, and tube passage problems are going to be likely. What you want to do is to compromise the view in order to reduce the angle from pharynx to larynx. This involves dropping the blade tip so that it is parallel to the floor, and may involve retracting it out of the vallecula a little. You can see this being done in the video. When the alignment of pharynx and larynx is good, you see a black hole. One additional advantage with having the blade further out is that you see your endotracheal tube earlier, and it helps with directing the tube into the larynx. Personally, I find it preferable to insert the endotracheal tube alongside and hugging the blade. I think it keeps the endotracheal tube tip away from the pharyngeal wall, and it reliably appears on the video screen. I would also recommend trying to keep the endotracheal tube in a sagittal plane. Not uncommonly, I see people with the tube in this position, angled off to one side, and they often poke around the arytenoids as a result, and it is only when the endotracheal tube is brought into a sagittal plane alignment that they can then reach the cords. This can be seen on this video and also a real life one I'll show later. If you let the endotracheal tube fall to the back of the pharynx before tilting it towards the larynx, then it tends to be angled quite anteriorly, and this increases the likelihood of tube passage difficulties. Instead, it is better to lift vertically upwards on the tube before advancing it to flatten the approach angle as much as possible. You should advance the tube gently through the cords, and you will usually make contact with the anterior wall of the subglottis. At this point, you or your assistant should withdraw the stylet by 5 centimeters. before advancing the tube down the trachea. You may need to rotate the tube at this point, and I'll cover that next. If the tube advanced successfully, then the stylet should be withdrawn in the direction of the patient's feet to stop it pulling out the endotracheal tube. When it comes to advancing the endotracheal tube down the trachea, the choice of tube does make a big difference. Straight flexible tubes with bullet tips, such as fast-track tubes, usually advance very easily. Preformed PVC tubes that are stiffer can be very problematic and require extra steps to overcome this. This graphic on the left depicts a standard left-facing bevel lodging between the first and second tracheal rings. If the tube is rotated 90 degrees clockwise, then it takes the curve of the endotracheal tube out of play, and in addition, the bevel direction now becomes favourable for advancement down the trachea. This can be achieved by rotating the whole endotracheal tube stylet assembly if there is room, and I'll demonstrate this on the next slide. Alternatively, the tube can be rotated 90 degrees on the stylet. This technique has been called right at the rings and is contrast to the left at the larynx maneuver required when trying to railroad the same tube through the vocal cords over a bougie. This video shows how, if there is room, the stylet endotracheal tube assembly may be rotated right to allow advancement. If the previous techniques to help advance the tube down the trachea have failed, then it is worth flexing the atlanto-occipital joint. As can be seen on these MRI scans, this tends to flatten the secondary curve of the airway, which may better align the tube with the trachea and enable the tube to advance. Airway injury appears to be more common when using VL as compared to DL. In particular, with hyperangulated blades, there is a potential blind spot in the pharynx. The upward force applied by the laryngoscope to facilitate view stretches the palatoglossal and palatopharyngeal folds, also called tonsillar pillars. This makes them taut and susceptible to perforation. It is therefore considered mandatory to look into the mouth when inserting the endotracheal tube and to be very careful with how you direct it. Unlike the CMAC and McGrath systems, the GlideScope system has different size hyperangulated blade options for adults, and choosing the correct blade is vital. The camera in the Low Pro 4 is significantly further away from the blade tip, and in many adults, the degree of insertion required to get the desired view will result in the tip pushing forcefully into the vallecula, creating an unfavorable angle from pharynx to larynx that we're trying to avoid. The Low Pro 3 is preferred for the vast majority of adults, and is only the largest 10 to 20% skeletally in whom the Low Pro 4 is indicated. So we have seen that as a primary technique, success is very high, and success is also high as a rescue technique after failed direct laryngoscopy. So the question is, who does it tend to fail in? In another study from Michael Aziz, the strongest predictor of GlideScope failure was altered neck anatomy with the presence of a surgical scar, radiation changes, or a mass. Reduced cervical spine motion was an additional risk factor. Very poor mouth opening is not listed, but I think it is likely that patients with very poor mouth opening would have been intubated with a flexible scope from the outset. To summarize, hyperangulated videolaryngoscopy usually allows very good laryngeal exposure, but in order to realize the potential for very high intubation success rates, good technique is required to overcome challenges delivering the endotracheal tube to the laryngeal inlet and advancing the tube down the trachea. This is an intubation sequence performed by a junior anaesthetist with comparatively little hyperangulated blade experience, and they're using a preformed flexible tube with a left-facing bevel. They insert over the midline and relatively quickly get a good view of the larynx. They're now aiming or trying to insert the tube into the mouth, and they actually lose the view that they had while they're doing that. They're now trying to direct the tip of the endotracheal tube into the view of the video screen. And it finally comes into view now, and it's hitting the right aretinoid because it's not aligned in the sagittal plane. It's rotated to the right. They need to rotate it into the sagittal plane, which they've just done now, before they can advance it through the cords. They remove the stellate there and try and advance, but it's not possible. They then try and rotate the tube and the stellate together, but there's not enough room in the mouth to do that. And finally, the tube is rotated clockwise on the stellate and it's possible to advance it. What you don't see here is that this whole thing takes well over a minute, so it's a very long intubation. So when should you use Macintosh videolaryngoscopy and when should you use hyperangulated videolaryngoscopy? It really does depend on the expertise of the person holding the videolaryngoscope. In the absence of gross anatomical abnormality, Macintosh VL has a high success rate and is usually quick. Whilst hyperangulated videolaryngoscopy may have the potential for higher intubation success rates, this last video serves to highlight how this is user and technique dependent and it is possible to prolong what might be termed an easy intubation. For that reason, unless you're an expert, you should be cautious about using hyperangulated blades in situations when you have limited time to complete intubation. I would include the patient undergoing emergency caesarean section in that category. Of note, the DAS intensive care intubation guidelines advocate Macintosh VL as first line, with hyperangulated VL suggested as a rescue technique. We have now addressed several of these problems. These two remain and featured in the obstetric GA cases I talked through. Can't get the blade in the mouth is a particular problem in the obese obstetric patient. Patient positioning has a significant effect on the ease of blade insertion, be it a standard Mac blade or a LoPo blade, and the next few slides that address this relate to laryngoscopy in general. The sniffing the morning air position for intubation was recommended by Sir Ivan McGill in 1936. It has since been shown that lower cervical flexion flattens the secondary curve in green, whilst extension at the atlantoaxial joint flattens the primary curve in blue. Compared to a supine sniffing position, elevating a patient's shoulders and torso appears to confer additional benefit for direct laryngoscopy in most patients, but especially the obese. The endpoint used for ramping in studies is often horizontal alignment of the external auditory meatus with the sternal notch. Ramping is usually achieved one of three ways: with pillows under the shoulders, with inclination of the back or indeed entire operating table, or with a purpose-designed wedge like the Oxford intubation pillow that we have in main theatres. All options will be compromised if the patient slides down the table, and foot plates may be used to prevent this. The green line depicts the spine, and it can be seen that with pillows under the shoulders, the head is elevated by lots of thoracic and lower cervical spine flexion, whereas the other methods involve inclination of the whole torso. In addition to improving laryngoscopy, ramping achieved by inclining the torso facilitates more effective pre-oxygenation, increased safe apnea times, and easier face mask ventilation in obese patients. Whether this is the case for ramping using pillows is less clear. The FRC is improved in pregnant women who are ramped. A further key thing to understand is that the way you ramp a patient will affect the ease of laryngoscope insertion, and I'll address this in a moment. When using ramping, it is important to bear in mind that ramping has cardiovascular effects, and deramping immediately post-intubation is often appropriate. With the pillow under the shoulders technique, the horizontal alignment of the external auditory meatus and the sternal notch is achieved with thoracic and lower cervical flexion, and the chin tends to be close to the chest. If you try to insert the laryngoscope as pictured, then the handle contacts the chest and insertion is difficult. The problem tends to be a bit worse with the low pro. What you want to do at this point is extend the atlantoaxial joint to create space, but because of the extent of lower cervical flexion, this is not possible. You are therefore stuck in this position here, and the only way you can really get round it is to insert the blade at an oblique or even 90-degree angle before straightening it in the mouth. Just in case you wondered, the GlideScope Mac blades have very similar handle lengths to the stubby-handled Macintosh laryngoscopes in maternity. The handles of our standard disposable Macintosh laryngoscopes are about 2 centimeters longer. Things tend to be easier if the external auditory meatus and sternal notch are lined up by inclination of the entire torso. There tends to be more space between the chin and the chest. As there is relatively little flexion of the lower cervical spine, it is possible to extend the atlantoaxial joint and create yet more space to allow the laryngoscope insertion. A limitation of this position is that there is minimal lower cervical spine flexion. And so if you're performing Macintosh laryngoscopy, then after inserting the blade into the mouth, there may be benefit gained from manually lifting the head to get into a sniffing position. This may or may not be necessary and likely not required if a hyperangulated blade is being used. If you do manually lift the head, then the top section of the table may be lifted into place to support it before intubation. Hopefully understanding the effects of different positioning maneuvers may help you reduce the likelihood of you experiencing laryngoscope insertion difficulties. I'm very conscious, however, that translating them into the real world is challenging when the patient also requires lateral tilting and you are having to convert to GA mid-caesarean section. Very briefly, if you find that when you're using a hyperangulated blade there is no room to insert the endotracheal tube, then try reinserting the blade to the left of midline, and if that fails, insert the tube and then the blade. Thank you for listening to this whistle-stop tour through videolaryngoscopy. I would encourage you to go away and practice hyperangulated videolaryngoscopy, because if you invest the time to become expert, it is a game changer for your practice. These are my references. Please feel free to ask questions.